Hello, and a very, very warm welcome to you all. Good afternoon to some of you who are joining us, and good morning to those of you tuning in from the UK and Europe. My name is Professor Maggie Dalman. I'm Vice President International for Imperial College London and a Professor of Immunology. It's a real joy and pleasure to chair this Imperial Global Science Policy Forum session. As I'm sure you're all aware, Imperial is one of the UK's most international universities and is a world-leading institution of science, technology and medicine. We see the Global Science Policy Forum as a vital platform for convening our international and external partners and to focus on some of the most important global challenges that we face. And it's also a great opportunity for us to showcase Imperial's creative, international and multidisciplinary scientific research and technological innovation. Today's session marks the 7th event in the successful IGSPF series, and it's the first session to be delivered as a virtual event. As we are all so aware, the novel coronavirus is having an unprecedented impact across the world. And now, really more than ever, universities, governments, policymakers are seeing the importance and value that international research, collaboration and knowledge sharing can bring. The COVID-19 pandemic has caused us to make a number of really rapid but very profound changes in the ways that we work and operate as scientists and a university. But one thing that has not changed is our commitment to working with international colleagues and partners. It's clear that the pandemic, as well as other global challenges, cannot be solved by one country or less still by one university alone, and that we will need collaboration and cooperation from everybody, including support from our international partners and collaborators. Now more than ever, we must nurture our scientific partnerships and continue to share and learn from one another. Through collaboration, sharing of data and results, and educating the next generation, we will make a difference in this and other global challenges. We would welcome conversations with you to learn more about the ways in which your countries, your governments, and industry stakeholders and communities are responding to the pandemic. I'm proud to say that Imperial College London is really at the leading edge of the global response to COVID-19, and I'm delighted to be joined today by some of our amazing academics who will be sharing their experiences in supporting the global efforts to combat COVID-19. And I wanted to really start by thanking all of our speakers for being here today. I know how very busy you all are at the moment. Thank you also to our audience for being with us and for participating in this important discussion. Please do feel free to ask questions throughout in the Q&A box and during the panel discussion. Now I'm going to turn over to Ashley Saunders, the programme manager for this event, to say a few words and outline the format of today's session and how we use technology to ask questions. Ashley, over to you.
Thank you, Maggie. Hello, everyone. I've had the pleasure of welcoming many of you to the Imperial Global Science Policy Forum over the years. But for those of you who don't know me, my name is Ashley Saunders. I work in the International Relations Office at Imperial College London. It gives me great delight to welcome so many of you to our event today. Thank you for joining us. I want to let you know that this event is being recorded and will be made available for viewing following the event. A link to the recording will be sent out to everyone who registered via Eventbrite. In terms of the format for today, we will first hear from our 4 speakers who will deliver presentations on public health, diagnostics, innovation and vaccines. Following this, we will have a panel discussion chaired by Professor Dalman with an opportunity for questions from our audience. Please type your questions in the Q&A box throughout the session and note if you would like to address your question to a particular member of our panel. The Q&A box is located to the right-hand side of your screen. You have the option to post questions anonymously or to use your name. If you use your name, this will be visible. I would like to encourage you to make use of the thumbs up feature to show which questions you would most like to be answered by our panel. And finally, I would like to offer my personal thanks to our chair and our speakers for their time today. I'm looking forward to the discussion. Without further ado, I will hand you over to Professor Maggie Delman. The floor is yours.
Thank you, Ashley, and I don't underestimate the amount of work that goes into running this sort of a programme, so thank you for your organisational efforts. So let's get on with the main business, and it really gives me great pleasure to introduce our first speaker, Professor Helen Ward from Imperial's School of Public Health. Helen has 3 decades of experience in research, education and applied public health, working on the epidemiology and control of sexually transmitted infections and HIV, and the development of participatory approaches in health research. Helen's worked on a number of studies that look at community responses to the COVID-19 pandemic. Helen and her colleagues have instigated the Reactive Study, a major programme of home testing for COVID-19 to track the progress of infection across England in the non-hospitalised population. The real-time assessment of community transmission, REACT, programme works with public volunteers and patient advisors to determine first how widely the virus has spread, and second, the accuracy and ease of self-antibody tests. Helen has also been working on the Chariot COVID-19 Rapid Response, CCRR, study, which considers the wider impact of COVID-19 lockdown on the mental and physical well-being of, in particular, older people. Helen, many thanks for joining us today. We really look forward to learning more about your work and how you see the future of public health as we seek to build resilience in our society and pandemic preparedness across the globe. Helen, over to you.
Thank you very much, Maggie, and it's a pleasure to be here, and welcome to everybody who is watching this from around the world. So public health has never in my lifetime had such high profile as it has now. Everybody knows about public health. Everybody thinks that they are a public health specialist. Any of you who are on social media will see that everybody on there is an armchair Twitter epidemiologist. So why does public health matter in a pandemic? Can I have the first slide, please? Thank you. I want to focus on 3 areas of public health that are critical in responding to an epidemic, and I think science and Imperial is playing a role in each of these. The first is surveillance. You cannot fight an epidemic, you cannot fight a virus if you don't know where it is, and so the notion of the virus hunter is critical, and I'm going to talk in a bit more detail about the React study that Maggie mentioned there, which I describe as knowing your epidemic. It's something that we've learned around 30 years of HIV control, that if you don't know where the virus is spreading, you are really unable to respond. You can't just respond in a blanket way across the whole population. You need to hunt down the virus and give the right interventions to the right people at the right time. Secondly, in terms of the response, clearly there's had to be a very widespread response to this particular virus, and that includes promoting health and encouraging people with the basics of hygiene and so on, in terms of social distancing and their own personal behaviour. That actually has been what has stopped the more widespread experience of SARS-CoV-2 so far. It's been the lockdowns and the changes in behaviour that have had a huge impact. And that's individual health promotion and group level health promotion, but also health protection. Now, health protection is a key part of public health. That means we don't just leave it up to individuals. We actually put in place structures to our response, whether that is the correct protective equipment for staff in hospitals, etc., but also regulation and enforcement of the rules that we're trying to develop. And finally, we need proper health and care services to reduce the impact. Those are all things that public health can do, and also that we need to research. And the final bit I'm going to touch on at the end of my talk is about communication. None of this can happen without trust, and there is enormous need for good communication across the population. That too is an area for scientific research as to how that happens and how you build that trust. Next slide, please. So how do you know your epidemic? Well, the basics that we have in place in most countries is that we count cases. We count people that have been diagnosed now that we have a test. But that's completely dependent on how widespread testing is, who comes forward to have tests. So really, it doesn't tell you very much. Some people will have heard the arguments around that President Trump recently is alleged to have said, if you stop testing, then you reduce the cases. That's always been the case. If you don't test, you don't have a problem. Well, you do have a problem, but you can't see it. So that's of limited use, to be honest, unless you've got extremely widespread testing. Deaths, unfortunately, are our best way of surveilling this at the early stages, and we have been monitoring those across the world and comparing those. But the final thing, which we are developing, I think now, as we're moving into the better experience of the epidemic, is active surveillance. It's case finding, where you decide who you need to test to find out how widespread this is. This is particularly crucial, as I'm sure we'll hear a bit more later on. This virus has a very wide spectrum of disease. Some people are extremely ill and will be diagnosed because of that. Others will have very few or even no symptoms, and but they can transmit. So if we don't find them, then we won't be doing our job very well. Next slide. So the React studies, there's two main parts of this. In order to find cases across the community and not just count the ones that are sick or in hospital, we need to go out to the community. We can't have all those people coming into testing centres at the moment. Therefore, we designed this programme to test people at home, and ideally for them to test themselves. So there's two parts of it. The first is to look for the virus itself with antigen testing. So these are nasal and oropharyngeal swabs. People swab their own throats and nose and send these off. This has to be done at massive scale because actually certainly in the UK, of 3 months of lockdown, the virus is not that common, thankfully. It's not gone, but there's not that much around. So you have to do large numbers. So we're doing this. The first round was in 120,000 randomly selected individuals. The next round is 150,000 to get an idea of the prevalence now. The second part of this is the React 2, which is to look at antibodies. Now, antibodies are the way that the body responds to infection, and this will tell us how many people have had exposure and mounted an antibody response. So it is a measure of the cumulative prevalence of this disease over the past 6 months since it first emerged. Antibody tests can be done in a lab, but again, we don't have the resources to do that at scale, so we've been developing a way of using self-test finger prick tests. Next slide. The React 2 studies, this has been complex because these tests were not perfect, even though there's over 200 or more of them in the market now. We decided to start very carefully with looking at the accuracy against people who are known to have had PCR confirmed cases of COVID, and then look at how many of them post 21 days were positive on these tests. So we've done a lot of accuracy on that. My team has done a huge amount of work on the usability. There's no point in sending these out to hundreds of thousands of people if they can't use them. So we worked with public volunteers who have tested them at home, who've joined our online discussions and told us feedback. And then we've taken them out to nearly 15,000 people just to see if they can use them, not to actually measure the prevalence in that. This was to see how usable they were. And over 93% of people in that large study said that they were happy to use them, so they're very acceptable. And almost all of them, about 95%, got a valid result from the test. So we're very confident that people can use them. Even though they're not perfect, we can adjust for that and get estimates of how common this has been and how far it's spread across the whole of England. Next slide. So that's the study 3 is the usability. Study 4, we're comparing in key workers to see details in them. And at the moment, the most exciting, if you like, for me is the next one, next slide, which is study 5. It's a national seroprevalence study of home-based, they're called lateral flow tests. So this is in the field at the moment. We're randomly sampling. We've already got nearly 70,000 people have sent in their results, and we will be releasing the results hopefully in the next 2 weeks. And this is showing us just how widespread this virus is, and it's also telling us which particular parts of the population have been most severely affected. So we can look at local level at the effects of determinants such as age, whether people are key workers, ethnicity. We can do this at scale and start to understand if it's not just about how severely ill different subpopulations get, but whether they get exposed at all. Next slide. Final thing before I stop was I just wanted to say something about trust. The World Health Organization talked about the infodemic that happens with all epidemics, but particularly around this one with social media. There's a lot of information out there, but there's also a lot of misinformation. And it's a key part of public health to actually help deliver good, reliable information and to build trust. So my final slide, next one, is that right at the end of January, we decided to launch a course about how we do science around something like this coronavirus. And we've been building this course. It wasn't a perfectly formed, obviously didn't know everything in January. So we built this course over the last few months. It's a free course online through Coursera, and we've had great support from the Community Jameel, for example, to allow us to do this. And this has allowed some of our key researchers to share their methods with a very wide audience. And we've had over 100,000 people taking this course. And we hope that this is helping to counter some of the misinformation out there and build more trust both in the science and also the response. So thank you.
Thank you, Helen, very much indeed for that wonderfully balanced presentation. I think the whole business about trust and communication is something that just cannot be underestimated. And I'm not sure everybody's getting it quite right at the moment. But with people like you on the case, I'm sure that will improve. So now we're going to move from public health to diagnostics. And Helen's been talking about testing for the prevalence of presence of both coronavirus itself and antibody responses to the virus, and how key these are in changing people's behaviour. But as Helen also spoke about, we've really not quite got to grips with this, at least in the UK, in a nationwide sense. So our next speaker is Dr. Pantelis Georgiou from Imperial's Department of Electrical and Electronic Engineering, who's going to speak about his work on developing new testing devices. Pantelis is the head of the Bio-Inspired Metabolic Technology Laboratory in the Centre for Bio-Inspired Technology, a multidisciplinary group that invents, develops and demonstrates advanced micro devices to meet global challenges in biomedical science and healthcare. He's developed a diagnostic platform which uses microchip technology paired with a smartphone app to rapidly identify whether or not a person is positive for the SARS-CoV-2 RNA from either the nasal or throat swab. This addresses the need for new accessible point-of-care diagnostics, which can be rapidly deployed in hospitals or even at home for front-line staff or people who are in vulnerable groups and so on. And it really offers the possibility of real-time tracking of the pandemic. So Pantelis, we're very much looking forward to your presentation, and over to you.
Thank you. Thank you very much, Maggie, and thank you all for attending our talks this morning. I'm going to tell you a bit about the work that we've been doing to address COVID-19, which mostly builds on some of the rapid diagnostic technology that we've been developing in my lab, which uses microchips. So I first need to explain what a microchip is. Well, the microchip technology we use is exactly the same technology which is powering your mobile phones and every single consumer electronic devices. It's a small piece of silicon on which we can actually build a complete system with integrated sensors And because we're leveraging the economies of scale of consumer electronics, it's quite a cheap technology. Within my lab, we use microchip technology to innovate next generation medical devices, addressing the current challenges we're facing in healthcare. And there's several applications. One is creating bio-inspired systems, such as an artificial pancreas treatment of diabetes. We can make wearable systems to monitor vital signs. And today I'm going to focus on diagnostics. I'm going to tell you about what a lab on a chip is. So lab on a chip, as its name suggests, is taking the functionality of a big lab and miniaturizing it on a small chip with many, many integrated sensors to analyze a sample. And that's been the core technology for our rapid diagnostic for COVID-19. But a lot of the work that we do also targets, the low middle income countries where there's a huge need because they don't have an abundance of resources such as access to healthcare and community hospitals. And we were working rapidly to try and develop some diagnostic technologies for the likes of for infections such as malaria or dengue. But all that's been put on hold, as I'm going to show you, because we're now addressing COVID-19. This is the world we currently live in. When you wake up in the morning, you're feeling a bit fluey, and you have no idea, is it COVID, is it flu, is it hay fever? What this is brought to light is the urgent need for a rapid diagnostic technology that can tell one if they're infected with the coronavirus. And that can have huge implications. I mean, the UK government's identified that we need of up to about 200,000 tests per day. And the reason for that is, to be able to track the outbreak and the spread of the virus in real time. In doing so, you'll be able to combat coronavirus because, as we saw through the example of Leicester this morning, you can shut down local hotspots and then contain the spread. Equally, on the other side of the spectrum, if you had access to a rapid diagnostic test that could tell you if you were infected, then that could inform you as to whether or not you should self-isolate or whether you could go to work. So there's huge need for rapid diagnostic tests which can identify whether one's infected. If we look at the current diagnostic techniques, at the moment you take a nasal swab and you send it off to the lab, and that can take up to a few days or even up to a week or so. It needs dedicated expertise and dedicated facilities, and it's very user dependent. However, you are guaranteed to get the sensitivity and a quantitative metric as to whether you're infected. On the other side of the spectrum, we've seen the rapid diagnostic tests, the so-called antibody tests, which are very cheap. They're very quick because they work from a drop of blood and they give you a real-time indication. So they're quite affordable and portable. However, they only tell you if you've been infected with the virus, not whether you've passed the infection, not that you're actually infected. As we've seen in the previous talk by Helen, the gold standard is the RT-PCR, the polymerase chain reaction test, the molecular method, whereby you can get very high sensitivity and specificity and a quantitative result on whether you're infected. However, it's very lab dependent. These instruments are very expensive. It requires dedicated expertise, and it can take anywhere between 2 to 4 hours to run a test. By far the best diagnostic, I believe, it combines the best of these two. So it gives you the cheapness, simplicity, and speed of a rapid diagnostic test, but the sophistication of a molecular method, such as PCR. And I'm going to show you how that's been made possible with microchip technology. Thankfully, the World Health Organization has also given us a spec sheet. As an engineer, I like to design to specs, and they've given me a spec sheet as to what a rapid diagnostic test should entail. It should be affordable, so it's cheap and deployable, sensitive and specific, so it can identify exactly what you're looking for. It should be user-friendly, so that you can easily use a device and it can have impact in its use case. And it has to be rapid, so that gives you results as soon as possible. It has to be robust, equipment-free, and deliverable to end users. And microchips are suitable for that because with microchips, we can integrate many, many thousands of sensors and molecular methods in a device without the need for any sophisticated labels on the molecular methods. Therefore, we do not need any bulky optics, which then makes it possible to make a handheld device, which is completely lab-free. Also, because we can integrate instrumentation directly with our sensor, it means we can achieve very, very low levels of noise, which means we can have very, very high limits of detection, which then translate to being able to make a very, very sensitive sensor for identification of COVID-19. Because we can integrate many, many thousands of sensors, it means we can interrogate panels of markers as well, which only leads to a more accurate test. And this has been proven using what's called ion-sensitive field effect transistors, as I'll show you in the next slide, because with ion-sensitive field effect transistors, we can detect the presence or the absence of viral RNA. And this is our current state-of-the-art chip that we're using. It has 4,000 sensors, and in real time on this chip, you can see on these 4,000 sensors, we then compartmentalize with microfluidics our molecular methods, which identify the presence or the absence of DNA or RNA. And the way it works is you have a target which you're looking for. We design a primer which identifies the target that you're looking for, and in our case, it'll be the SARS-CoV-2 virus. And in the presence of an enzyme and nucleotides, there's an extension which releases protons, and the sensors on our chip detect these protons. But also more importantly, unlike PCR, which thermocycles between different temperatures, we work at one temperature. So we have an isothermal assay, which is very, very specific and extremely fast. We can identify the presence of a virus in under 10 minutes. And because we're leveraging consumer electronics, we use standard off-the-shelf components such as printed circuit boards in our microchips. And what this results in is a very, very cheap diagnostic test. Our bill of materials for this device for 1,000 units is just £11. And that has a sophistication of a molecular method that's used in a PCR machine, which currently costs up to about £60. On top of our microchip, we put our molecular methods. And when it detects the presence of a virus, it then amplifies and gives us this sigmoidal curve. And here's our end-to-end diagnostic. So it takes an extracted sample. In the presence of COVID, it's from a swab. You put it on the device. The device is a handheld unit. So it's the first handheld molecular test. In real time, it detects that the virus is present and communicates that to a mobile phone. But at the same time, it geotags the results so that we've got real-time surveillance. So it actually maps the moment that the infection is detected from the device as well. And that can lead to further usage of the data by epidemiologists and also for surveillance of the virus. Before working on COVID, obviously we were addressing another huge need in terms of antimicrobial resistance. And you can see here, like-to-like comparison with the big instrument, that we're detecting that the pathogen is present in under 7 minutes. In terms of mobility, last summer we were in Ghana showing that we could detect the malaria parasite. And we showed that we could detect it in under 15 minutes as well with very accurate quantification. And we were set to go back there this summer to do a test in schools in rural Ghana by running the diagnostic in the back of a car in the form of mobile diagnostic. But COVID has happened, and as a team, we sought to address this huge pandemic. So we've repurposed now the device over the last few months to detect the SARS-CoV-2 virus, and our target has been in under 20 minutes. I'm pleased to say that our first tests have resulted in very, very low time to positives. Our average, which we're about to publish, is that we can identify the SARS-CoV-2 virus in about 12 minutes with an extremely sensitive limit of detection down to 10 copies per reaction. And I'm also pleased to say that we've been funded by the Imperial College COVID Research Fund to now scale this up to 1,000 tests and also conduct a large-scale clinical validation in Charing Cross Hospital. Here you can just see what the device looks like in terms of its form factor. So you can see it's a very small handheld device, and in real time it communicates to your mobile phone. And you can have several cartridges for different pathogens, identifying the presence or the absence of an infection. In the interest of time, I'll just go on to the next slide. And here you can see our surveillance system. So in real-time updates to our surveillance system, which can give you very detailed information as to where the hotspots of infections are taking place. And all this is being used to move forward to the next wave, where we're looking at obviously running it in a mobile diagnostic system where we can drive around and do on-the-spot tests in the community, in care homes and in schools. So we've delivered a rapid molecular diagnostic, which can detect the SARS-CoV-2 virus in under 20 minutes. It's sensitive, specific, and quantitative, so it has a sophistication of a PCR. And it's the first mobile platform which allows it, which also geotags results, provides real-time surveillance. It's lab-free, it's low-cost, and it's scalable, and it's adaptable to new pathogens within a month. So we've shown that we can repurpose it in several applications to detect emerging strains of infection, not just in COVID-19, but also in antimicrobial resistance and in tropical infectious diseases. And now our next stage, will look at doing a large-scale clinical validation. We've set up a supply chain to be able to scale this to 1,000 tests, and we're moving forward towards community testing, LMIC deployment, and also syndromic monitoring, looking at predicting using machine learning as well, the necessity for admission to hospital using the diagnostic. On that note, I'd like to thank you all for listening to my talk. Thank my great collaborators in medicine. It's been a multidisciplinary effort combining engineering, medicine, and molecular biology and virology. And also thank all my funders for helping realize this work. Thank you very much for your time. Over to you, Maggie. Thank you very much.
Thank you. Thank you so much, Pantelis, for such an interesting presentation. And I think it's a very fine example of that multidisciplinary approach to solving problems, which is so much a part of the DNA of Imperial College London. And I think that makes a very fitting transition to our next speaker, Dr. Simon Hepworth. Simon leads Imperial's enterprise team, which supports and develops innovation and translation activities across all of our departments and faculties and campuses. He is an engineer by training with a DPhil in neural network-based control from Oxford University. Simon was a founder of the corporate partnerships activity at Imperial and has led the formation and growth of a number of significant initiatives that today constitute the university's enterprise offer. Simon also leads the MedTech Superconnector project, which actually brings together 8 academic institutions across London, and which is designed to facilitate the early stage development of innovative medical technologies from devices and diagnostics to digital healthcare solutions. Simon, thank you very much for joining us today, and over to you.
Thanks, Maggie, and hello, everyone. I'd like to give you a brief snapshot of some of the amazing work of our students and staff, progressing their ideas and discoveries towards societal impact during the COVID-19 lockdown period. Necessity is the mother of invention, and many new needs have arisen as a result of COVID-19. Some of them directly related to health and medicine, some of those to how our lifestyles have changed. So with that backdrop, let's get started. Next slide, please. So right at the start of the outbreak, we were focused on emergency treatment, and we saw a number of initiatives that effectively pivoted towards treating COVID-19 patients. I'll give them 2 examples here. One is a startup called Medici, based in our White City incubator, led by Christina here. And their approach is around blood filtration, so dialysis type technology, using magnetic properties of blood and how that changes when there are infections. Their prime route is still sepsis, malaria, leukemia, but they felt there was a potential here to treat COVID-19 as well and adapt their technology. The second example is around ventilation. So our bioengineering team developed an emergency ventilator product. What was unique about it was that it was built off standard parts. So this was back in March, where there was a critical shortage of ventilators and the components that went into them. And this was designed over about a 3-week period, closely working with our clinical teams in Imperial College NHS Trust. And that design is now available for any manufacturer to license in the world. And it was Michael's great work and team members with him. Next slide, please. A totally different use case here is keeping people hydrated. So this is a company called Jelly Drops. It's a student-led team. Their prime mission is dementia patients, recognizing that dementia patients forget to drink and so they become dehydrated, but they don't forget to eat sweets. So their approach was to make water appear as sweets in a beautifully decorated box, as you can see here, to help patients remain hydrated. And they've taken this approach as well to provide hydration for COVID patients. Next slide, please. We then started to think about, okay, how do we help with the protection of our key workers, and in particular the NHS frontline staff? And there was a great shortage of PPE, personal protective equipment. And we had several teams that actually worked on the face visor, so a product that just comes down across your face and provides a film to restrict the air that can reach your face. And we had student teams doing this at a hospital up at Cambridge, and we had the Imperial College Advanced Hackspace team also work on a new product for this, again trying to source materials that were available at the time. A whole new design, worked with the infection team at Imperial College NHS Trust, and to date they have provided close to 50,000 face visors for the hospitals. And what's also unique here, you can see the picture there. This is a floor of the iHub, which is our translation building at White City. So one empty floor was remaining and made available as a socially distanced assembly line here, and that ran for a period of a couple of months. So great ingenuity there. Next slide, please. So Pantelis talked about the world of testing and diagnostics, and we have several initiatives focused on this. And Pantelis is one that looks very exciting in terms of a low-cost technology. One that's available now at a slightly higher cost point is DNA Nudge. So this is led by Professor Chris Tumizu, and the backdrop you see here is his store in Covent Garden in London. And their prime use of technology is around nudging you to better shopping choices. So they take a sample of your DNA and they look at what your prevalence is to certain diseases, and then give you a scanner so that you can walk around the supermarket, test the barcode of the product, and then it will give you an indication about whether that product is good enough for you or not. Chris worked very hard to pivot his device and did clinical validation at A&E in one of our hospitals, and now has a product that is available to use by the NHS. So records time in terms of validation and making that available. And one of the real advantages of this is it does not need to be sent away to a central lab for testing. The machine can give you a very local test result within a couple of hours. So fantastic work there by Chris. Next slide, please. We move on from test and trace to vaccine, which is the real exit from the pandemic. Professor Robin Shattock is going to talk to you next about what we have established here around his technology. I will only say that it is a fantastic new business model around social innovation, as well as the technology inside it, but I'll leave Robin to describe it in more detail. Next slide, please. It's not just about the deep technology. Behavior also matters quite significantly. Weston Baxter here has looked at hand washing, so something that is common to us all, or not. So hand washing is not prevalent in all countries, and Weston has done some behavioural studies to look at why that is the case. And he's devised a single-use soap, something that you could carry around in a small bag or in your back pocket, that he feels will grow the prevalence of hand washing in all countries. And he did a study in Tanzania where a large bar of soap, if it was made available, was more synonymous with laundry or dishwashing, and so if made available publicly, may not stay long in public use before it's taken for those kind of activities. So a single-use product could be much more useful in that environment. Next slide, please. If we think about how behaviour has changed post-COVID, it's not that attractive at the moment to consider going on a highly packed tube train in London. So micro-mobility becomes quite an important factor. There are more people cycling. And in the last few years, we've seen a growth of electric bikes, just to give you a bit more power to help you on your journey. And we've got several companies working around micro-mobility. On the left here, we've got Bumblebee. They're working on a wireless charging technology that is much lower weight than conventional, and also a bit more forgivable to the alignment of the charger and the device. So that we think will be quite a success. Halation are looking at making cycling safer, so they are trying to nudge the behavior of drivers through clever lights to give cyclists a wider berth. And Dash have taken the opportunity to really do some market validation. They made some of their electric scooters available for free for key workers during the pandemic in London. So getting more people used to this kind of technology. Next slide, please. One of the things we've also experienced during the pandemic is having more parcels. So this has particularly worked out well for a startup that has got a device called Parcel Tracker. So if you live in your own home, parcels get delivered to your door, no problem. If you live in a place where there's a concierge or a front desk, the parcels go to that front desk, and you can imagine how they might pile up during a pandemic. And parcel tracking makes that much simpler for the people that run those concierge services. So they're doing very well at the moment. Next slide. We don't stop at Imperial, and we are building out our investor ecosystem at the moment, so we're open to all investors. One of the initiatives we have started is a very small seed fund just to get maybe 10 or 15 startups off the ground in deep technology. We launched this for fundraising on the first day of the lockdown, so we were very concerned about whether we would actually close the fund, but I'm pleased to say we did close it, and we closed it to around double our initial expectation at £2 million. That's a great addition to our ecosystem. Next slide. So I'll leave with this one to say just how important the ideas from our students and staff are as the sparks that change our world for the better. And with that, I will hand back to Maggie.
Thank you, Simon, for that brilliant presentation. I mean, it just never ceases to amaze me, the things, the ideas that our staff and students come up with. And obviously at the moment, that is just so important. But of course, it's important for all the issues that we face, and great strength to those staff and students. So actually, many of the speakers this morning have mentioned the vaccine and the importance of developing an effective vaccine, and it really being the way to getting us out of this current situation with multiple lockdowns. And so I'm really delighted to introduce our next speaker, Professor Robin Shattock, who's leading Imperial's development of a vaccine to SARS-CoV-2, and which, as Simon mentioned, employs a novel self-amplifying RNA technology. And Robin is obviously the person to speak to this, but I think there's a huge excitement about the technology that you've developed, as well as the application in this current pandemic. And partly as a consequence of that, it's fantastic to have heard, Robin, that you've been supported with over £40 million in grants from the UK government, and that's only one of two that have been funded in this country. And very exciting week last week with the launch of the first clinical trial. I guess you probably don't have any data to report back to us on that quite yet, but we look forward to hearing what you have to say for us today. Robin, over to you.
Thank you very much. So yes, we've been working on developing a very new approach to vaccination, and have been able to apply this to the COVID-19 pandemic. We had been working on this vaccine approach for a couple of years before, really in preparation for pandemics. And actually we presented it at the World Economic Forum a couple of years ago, saying that pandemics are coming, we need a platform that can work quickly. I don't think we were anticipating quite how soon a pandemic would occur. We probably thought it was going to be avian flu rather than coronavirus. The advantage of our technology is that essentially we make vaccines through a fully synthetic process. So vaccines traditionally are made by growing a virus or a bacteria using cells, animal products, and very large facilities. We can actually generate vaccines at low cost in a low manufacturing footprint, and make millions of doses within weeks, which obviously is very appropriate for rapid response. So our approach is really quite simple in many ways, but I think rather elegant. So if you look at this slide showing a cartoon of the virus, what we do is we take a small portion of the genetic code that actually has the instructions for making the surface protein, the red protein that you see sitting on the surface of the virus. And we take that genetic instruction and we make multiple copies of that in the laboratory synthetically, and then we insert that into microscopic fat particles. So essentially the instructions are captured in a droplet of a lipid or fat, and that is the basis of our vaccine. So what happens is that these genetic instructions are delivered as the vaccine into your muscle, and the particular form that we use means that once it is taken up by muscle cells, it actually amplifies the response, expresses that surface protein, and that induces a potent immune response. Now, I'll walk you through those steps in a little bit finer detail, just so you can visualize how the vaccine works. And I think that shows how it may be successful in making a very low dose vaccine approach. So as I've already indicated, the instructions, which are essentially RNA, genetic material, are encapsulated in these fat droplets. And these are very efficiently taken up by muscle cells and other cells at the site of injection. Once they gain entry into the cell, they then start to copy themselves, a bit like a photocopier. So you make multiple copies of the instructions and then engage the host machinery to start making multiple proteins. And so if you like, we go into a cell and we set up multiple production lines so that the cell then gets literally covered with this surface protein of the virus. Now that's not natural. The immune system recognizes that surface protein and makes antibodies that it will be protective when you see the virus. So to go through the whole process, we go from a virus, we understand the genetic material, we put it into those microscopic droplets, inject it into the muscle makes antibody responses, so that when you see the virus for real, there are antibodies that can block infection. And so it's quite an elegant approach. Now, does this work? Well, we've already tested it in animal models to see whether it induces the type of immune response that we would predict would be effective. And this slide, which shows the data from that experiment, indicates that at very low doses, we get antibodies that are able to neutralize the virus, render it non-infectious, at levels that are significantly higher than the levels we see in patients that have been sick and have recovered from COVID-19. So you can see that the vaccine does much better than nature. Now, we need to understand whether the same responses occur in humans. We're optimistic that they will, but that's why we've now moved into our clinical testing. So we've had to move very rapidly. We've gone from the sequence of the virus, which was made available by Chinese scientists, to designing our prototype vaccine, assembling that in the laboratory, testing it in cells, testing it in animals, and at the same time then working out how to manufacture this at scale and quality required for human use. And we started our clinical trial in London on the 18th of June. So in terms of our clinical development, we're here in June, starting with small numbers of individuals to check that it's safe and induces the right sort of immune response. And in the next few weeks, we will rapidly expand to enroll up to 300 participants, still studying the safety of the vaccine, studying the immune response that it delivers, and building a safety database so that by October, we can then go into large-scale efficacy trial in at least 6,000 individuals to see if the vaccine will prevent infection in the wider community. At the same time, we've been working on how to manufacture enough vaccine for the whole of the UK, and we now have infrastructure in place that we can produce up to 85 million doses in the first half of next year, should the vaccine be successful and should it be required. At the same time, we are working to do trials in other parts of the world and start to put in place manufacturing for global access, so that if our vaccine is really successful and other parts of the world want to access it, we're in a position to do that. And as Simon mentioned earlier, to do that, we set up a company. It's a social business. That means that it's a not-for-profit, in that any profit that it makes gets reinvested in maintaining the vaccine and making it available at affordable price for low and middle income countries across the world. Now, to do that, we're also starting to build partnerships with manufacturers in different parts of the world so that they can scale up the vaccine in different regional centres, making it rapidly available where it's needed most. Well, if you're interested in following the trial, we have a website and you can see the address at the bottom there. So if you'd either like to take part or just interested to see how the trials progress, this will be updated very frequently so you can see our progress over the coming months. All of that work really to go from concept to clinical trial has taken 6 months. And to put that in context, typically that would take 5 to 8 years. So we've had to do things in an extraordinarily quick time frame. That doesn't mean we've cut any corners. Safety has still been paramount and remains paramount to developing this vaccine. Now, none of that work would be possible without significant funding. We have been very happy to receive funding from donors that have been critically important in meeting some of those gaps, but also now significant funding from the UK government through different research avenues that have allowed us to progress with speed and develop a vaccine that can be rolled out in the UK if it's successful in the relative near future. So I'll stop there and thank you very much for listening to the presentation.
Sorry, thank you, Robin, for that wonderful presentation. It's really interesting to hear the process you've gone through and of course the fact that you're mindful to make this available across the world. I'm sure you'll be having a lot of people checking out your website in the near future. So I'd like to thank all of our speakers for their fantastic presentations, and I think I'm incredibly proud to be part of an organisation, Imperial College London, that's contributing in these many different ways to the global effort to sort out this pandemic. We have also nearly 2,000 key workers helping to keep our essential services running and supporting COVID-19 related research. More than 1,000 members of staff and hundreds of students are also volunteering to support the NHS. We've converted labs for NHS virus testing, including one that's able to handle around 1,500 samples a day. We're sharing our expertise in science, technology, engineering and medicine education, including COVID-19, with teachers and school pupils via a series of online materials for those that are not only working full-time at home, but looking after their children and schooling them as well. So now we have a panel discussion and all of our speakers are back here now on the screen, and we'll be very pleased to answer your questions. Please post the questions. Maybe you've already been doing that. Let me check. Use that. If you see a question that you're particularly interested in hearing the answer to, please use the thumbs up box, the thumbs up feature, to show that you'd like that question answered. Now, at the moment, I don't see any questions. Do we have, can the technology team tell me if we have any questions?
Maggie, I can see a question at the top.
Can you?
Which is for me. No.
Please carry on.
I'm happy. The question, if people can't say it, is that if successful, to what extent does the React virus hunter study need to be scaled up to be effective? And are there opportunities for health authorities in other parts of the world to draw lessons? So I think that to scale it up, we are in discussions with the UK government and the Department of Health and Social Care about making this larger. For the antibody studies, it's quite powerful doing 100 to 200,000 of these tests a month. We feel we have power to look in quite a lot of detail. But with the antigen study, the scale of the study depends on the scale of the epidemic. So the fewer cases, the more people you need to test to find them. So we will be iterating and changing that as we move forward. We will, of course, share, and we are sharing data as soon as we get it with the public health system. And this is just one part of a growing surveillance and case finding intelligence network that's been developed. I think what's interesting to have this as a research initiative as well as just case finding is that we are collecting important data so we can start to look at patterns, look at what kinds of contacts people who are infected or people who have been infected, what are the key risk factors and determinants of that. And we're also very grateful that the people involved in the study have, most of them also sign up to be contacted again for future research, which means that we've got lots of people whose status we know, who I'm sure many of whom will be very interested if they're contacted again, for example, to take part in one of Robin's larger trials going forward. So we're setting up a kind of volunteer, a set of volunteers who want to take part in this kind of research. The second question for sharing lessons with other countries, other health authorities, yes, definitely. I think it has been a much bigger effort than I expected to actually get to the stage where we know how well people can do these tests at home and how useful that technology is. We are hopeful that further technologies will make this even easier, but we are sharing those. We're already starting to share the lessons that we've got with other researchers. So we will continue to do that.
Thank you very much, Helen. I am having a bit of difficulty with these questions, so people are posting them into the chat box, but I got one here from Roman. Times quoted for the detection probably refers only to the reaction on a chip. How much time and effort is required for sample preparation? Could it in principle be infectious? Could it be done directly from the saliva? Pantelis, maybe you're...
Yep, so I can comment on that. So in our approach, as you've seen, we've opted for an external sample prep module, and that's because we're creating a versatile platform which works for both the nasal swabs and blood. Our sample prep module at the moment can extract the RNA for our chip in under 10 minutes, and the average time for detection on the platform is 12.5. So we're still trying to hit the target of under 20 minutes. We believe it's feasible. In terms of if it's contagious, the moment the swab's been put inside the tube, which contains the reagent mix, it inactivates the virus. So at that point, it's not contagious. So provided that swab's taken with precaution by a professional, we don't believe it's gonna cause any spread of the virus. In terms of saliva, as I mentioned, so the platform is versatile in that sense. It could be used for saliva as well. If there's biomarkers in saliva which indicate the presence of COVID, then we could create methods to detect those using the platform as well. And that's the advantage of our method in that we're not held to one method of sample prep. We're actually versatile, and we've demonstrated it both for swabs and blood.
Thank you very much. There's a few questions appearing about some of the commercially available tests and whether they're actually any good or not. I don't know, Helen and maybe Robin might like to comment on that. I
mean, there's one question about are the results of private tests being fed into national trials. Not that I'm aware of, although people are encouraged to, if these are antibody tests, then there'd be no particular reason why people would feed that in, although we do work closely with industry to try and make sure that if these are being rolled out, for example, they are being rolled out to a lot of NHS workers, then those data are, yes, being collected and collated with national data. In terms of how good the tests are, they vary, of course, as no test is perfect, whatever it might say occasionally when they get first released. And we are trying to set up systems whereby we can validate new tests as they come to the market, and again working with manufacturers to offer that. It's not that easy to validate these tests because most of the validations initially done are done on people serum from patients who are known to have had COVID, and they tend to have been taken in hospital, so they're quite severe cases. We're wanting to know whether it works in people also who've had mild cases that have also mounted an antibody response. So you have to get banks of serum from those people. So that's one of the things we've been doing. And you also have to have banks of serum from people who definitely haven't. So historic sera from before the epidemic. And the final thing that we've been doing is trying to test it in the real world. That is from people stabbing their own fingers and doing the finger drop, who we know have had COVID or not. And that is actually healthcare workers actually helping us do that. Robin.
Yeah, just to pick up on a couple of other questions that I'm reading. One of them is around natural immunity. So if people have been exposed to COVID-19, will they be immune from reinfection? And is there a need for a vaccine? The answer there is that people's antibody responses to natural infection is very varied. So some people make quite good responses and may well be protected. Some people make very poor responses and probably will be susceptible to reinfection. We obviously want a vaccine that produces protective immune responses in everybody and is very uniform in its response. But we anticipate that the vaccine ultimately will be used to those that have not seen the virus, but also those that have seen the virus and may well need a boost to their immune response to maintain a protection. Another question was related to side effects of the vaccine, and is a genetic vaccine going to be more potent than others? Actually, we anticipate that there will be very low side effects because we're using a very low dose. And certainly that's what we're seeing in the subjects that have already been vaccinated. We've seen no side effects to this vaccine so far. And another misconception that's often made with the type of vaccine that we're doing is that it might change your chromosomes. Our vaccine is obviously an RNA vaccine, which actually only hangs around for a very short period of time. It can't change any of your genetic material. So it's got an inbuilt kind of decay process. So again, it's very safe from that aspect.
So there are some questions appearing about collaboration and which areas we're interested in more for international collaboration, and indeed what would be the process for getting that sort of collaboration in train. And I think that's really relevant for everybody. So perhaps, Robin, you'd like to start, and then perhaps we can move over to Pantelis and Simon, and then Helen.
So we're definitely looking at two collaborations. We're looking to collaborate on clinical trials. There, one of the issues is looking at centres that have experience with previously running vaccine trials, because it requires quite a lot of experience to do well. And we're looking at manufacturing partnerships to make the vaccine more available in different parts of the world. So we're interested in both those approaches and very happy to be contacted.
From our end, we're looking for both clinical collaborations, which can find a use for the technology in a mobile setting, testing within the community. And also in terms of manufacturing, we're currently talking to different partners to see how we can scale this technology to meet the demands that have been set in terms of hundreds of thousands of tests per day. And in doing so, we'll be able to then deploy it more availably to all our partners.
Simon?
Yeah, I'll speak more generically. One of the questions is around, have we seen international collaboration grow through the pandemic? My honest answer is no, because I think we are a fantastically international place anyway. We convene a lot of different nations together in the academic work we do and in the commercialization work we do. And it's crucially important to us, whether it's feeding in grand challenges local to those countries, whether it's innovation partners to progress academic ideas into society, or whether it's investment into startup companies, for example, providing talented staff for those companies and often supplying in the technologies for them. So we remain deeply international, I think.
Helen?
Yeah, so I wanted to just mention that some of the other international collaborations that we have been doing right from early on in March was around understanding the behaviour and the public's response to this, because we know that in terms of overall patterns of disease, it's so important how people behave, and everyone will be aware of the discussions and the differences around, for example, mask wearing. And so we have got quite a lot of collaborations with people in Colombia, well, quite a few countries in South America, in Hong Kong, in Australia, the US and other parts of Europe, to look at behavioural surveys that look at how people's perceptions of the risks of a coronavirus have affected or seem to be associated with behaviour. So these are not big complicated studies, they're surveys, but actually they're showing some quite interesting things which do seem to affect the overarching success of control policies. So why it is that people in Hong Kong were already very well primed to see coronaviruses as very serious, and therefore to take up the social distancing and the hygiene measures much more promptly and extensively. And that obviously was one of the things that had a big role in their early effective response to this. So there's those other kinds of collaborations that are going on all the time.
Fantastic. Maybe I can ask a question, and this is probably directed at Robin. A lot of the focus has been on vaccines that induce an antibody response, and you talked about that this morning. But there are different types of immune response that you can make to viruses, which can also be responsible for clearing the virus. And I wondered if you might talk a little bit about that and how your vaccine and other vaccines might be inducing those sorts of responses.
Yes, that's a great question. I mean, there are two main arms of the immune response. One is antibodies, which can bind and neutralize the virus. The other is your cellular response, particularly cells that can recognize infected cells and kill them so that those infected cells are deleted. Now, our vaccine induces both types of responses, antibodies and cellular responses. And that's really the best of both worlds, because if the virus gets past your antibodies and gets into a cell, you've got a second line of defense where the cells can actually be killed by these killer white cells. So that's an important consideration.
And in terms of similarities and differences between all the different vaccination strategies across the world, of which there are many now.
Yeah, so there's quite a few different approaches, and they all have their strengths and weaknesses. It's important to have those different vaccine candidates because it's not clear which ones will really work well. And we don't know how much of an immune response is needed to provide protection. If actually only a very small amount of immunity tips the balance, then I would expect most of these vaccines will be successful. If it requires a high level of immunity, then we'll see that there'll be a kind of fallout of some of the vaccines that are less potent. Now, potency can often be increased by having more than one injection. So we deliver 2 injections spaced a month apart, and we can actually give more injections if it's required to boost that immune response. So we have a lot of flexibility if the challenge is harder than we anticipate.
Well, we've heard a lot about, actually, not so much today, but in the media about, you know, behavioural change, and actually we've seen some extraordinary things going on. I mean, I would never have imagined that London could have shut down as completely as it did, having lived here for most of my life. Helen, I wondered if you'd like to talk a bit more about this, how we get that, how we maintain that message under circumstances where we're seeing, you know, drawing back from the complete lockdown, which is a very simple message, to one which is now highly complex, and people A, are getting fed up with the complexity, and B, getting fed up of not going about their normal business. What sorts of things do we need to be doing now to really make sure we don't see a huge second spike?
I think that's a that's a very good and very difficult question. I think that as I said at the end of my talk, the most important thing here is that there is trust in the message and trust in the messenger. And I think a lot of countries that have not done so well have had issues around that, if I'm honest, because you have to be, as you said, it's a huge sacrifice for many people to not go about their normal lives, and particularly those people, many people, who the impact of lockdowns means huge financial problems. They lose their income, and then it's very difficult. So I think we have to continue this idea that we support people socially and economically through what we're asking people to do, so that builds some trust. And I think we need to have stronger voices of scientists around why it is so important. So I do think that having the education and increasing science literacy and health literacy around this, so people believe it. If people don't believe that they need to do this, then they won't. So I think mixed messages is a real challenge. We need to have very clear messages, and it does get more complex as the response becomes more subtle. The lockdown it's simple, but it's so crude, telling everyone to stop. You just like halt and let's see where we are. But now we need to be much more nuanced and say, okay, we can find the virus and then put a ring around it where it is and try and suppress it. But that is more difficult. And I think you do need this balance, which is part of public health historically, of encouragement and health promotion and the enforcement as required. But to do that, you need to build this trust. So we work very hard to work with communities. As you know, Maggie, all the work we do around our local communities, just try and find out what are the challenges, what are the obstacles that people face to being able to comply with these new times and the new behaviours, and try and bring them along with us. So having lots of science engagement, lots of events, all shifted online, of course. But I think that's a key part that scientists can continue to play in building up that trust.
I guess this is a question for all of you, really. And you've talked about scientists needing to communicate, but it actually is quite challenging, and particularly with this sort of thing that is affecting so many people in the country and around the world. How do you all feel about being approached constantly, I imagine at the moment, to be commenting on things that maybe you are comfortable with, but also things that perhaps you aren't comfortable with? Do you feel sort of adequately supported and trained to do that?
I mean, I can speak for myself. I would say yes. There's a very easy approach that if you feel uncomfortable, you just say, that's not my expertise. I'm not in a position to answer that question.
But these journalists will keep digging away and trying.
Yeah, you just keep saying the same thing.
And I would say that I think in public health it is quite difficult, because public health is basically just politics at the end of the day. Politics on top of the science. The science is the epidemiology and the collaborative working across many disciplines, but public health translates directly into policy, and that can get you into these conversations where you might say, well, it's not my area, but they want an opinion, and that I think is tricky. And I think sometimes we have to do that, because actually public health is also about advocacy, and advocacy does mean sometimes saying you need to do more of this, and you can't always just say the science gives an answer. You just have to say either the balance of probabilities are we need to, whether it's lockdown or not lockdown, and you also need to say, to share, you know, to be willing to share that uncertainty, but also to have an opinion. So I think it is tricky, that kind of science policy communication. I don't know if anyone else has a view on that.
Pantelis.
No, I agree, and I mean I've experienced a number of interviews, and it's always important to say the facts and be scientifically accurate, but also not dwell outside of to an area which you're not familiar with. So when they keep pushing in terms of questions which might be misinterpreted, you need to be honest about that and say, you know, it's not my area of expertise. In addition to that, it's always difficult, because you know you want to talk about the potential for the science, but you don't want it to be misinterpreted and escalated in a form that then puts additional expectations on what you need to deliver. So you need to be frank about that and honest on where things are.
Simon, thoughts?
I'm always the non-expert, so I'm very used to saying I don't know the answer to that, but fortunately I'm surrounded by 1,200 academics that know a huge amount, so I'm in a privileged position.
But do you think we should be, you know, we're responsible for education of young people as a science, technology, medicine-based institution? We tend to kind of put our heads down and get our PhDs or get the data for the next paper that the boss is asking for. Do you think we spend enough time on this aspect of our young people's education, that is communicating about the science that we do, seeking advice and input from the public?
I think we've done a lot in the last few years to grow that area. I think it's very important for us, and I think Maggie, you've led some of this out in White City as well, in terms of the work we do with the local community there. So for those that don't know us too well, White City is our new campus, about 3 miles from our spiritual home in South Kensington, and it gives us an opportunity to engage with the local community that we've not had before in the museum district of London, if you like. And so some of the initiatives like the makerspace, where school children can come in to learn how to make a device or learn how to code, I think that starts some of the dialogue that we need to have with the local communities. And I think we do reach out to schools, so we've created course content for schools, and that's very helpful for primary school teachers in the UK and further afield, I think, Maggie, again through some of your work.
Yes.
So yeah, I guess we can never do enough in this space. I think a number of our academics are role models for young children. I know my daughter is in secondary school, and there are posters of some Imperial female academics on the walls of her school. So I think we do make an impact there.
Thank you. There's a couple of new questions here, and this is actually one I'm interested in your response to as well. The whole thing about herd immunity, you know, should we be following that? Is it just a distraction? Views?
I mean, depends what one means by herd immunity. If this virus was left unchecked and went around the world, and over 80% of individuals have seen this virus, then it will be a very different space to a pandemic where the majority of the world has no immunity whatsoever. Now, typically, herd immunity can be induced by a vaccine that is 70 or 80% effective at preventing infection, would provide herd immunity across the UK if it was rapidly delivered to everybody across the UK, and would be the most effective way of getting us out of a period of going in and out of lockdown before natural infection had infected the majority of the population. But just looking for herd immunity without any restrictions would be so catastrophic in terms of its impact on the vulnerables in terms of health and fatalities, that it's not something that can be seriously considered outside the context of a vaccine strategy.
Yes, I completely agree with Robin on that. I was early on when it was first mentioned in some countries, both not just the UK, but in Sweden and so on, that this was a strategy and some belief that we could have natural herd immunity because some people didn't get too sick, I think was really misguided. I think it was wrong, and it should only be used. Herd immunity is a concept that we use to try and understand where and how to deploy vaccines, or to understand what is the eventual limiting of the spread of a natural infection. So it's an analytic sort of understanding. It shouldn't be a strategy in terms of natural immunity. And I think with something with a mortality across the whole population up to maybe, you know, of everybody who's exposed, possibly up to 1%, and in some groups much, much higher than that, then that would be condemning a lot of people to death. But also, as we know increasingly now, even people who have quite mild infection can get quite substantial long-term health impacts from this. So this is not just a cold or a, not that flu is mild, but a flu that once you've got over it, you're better. There are obviously some long-term immune responses and some damage, and we're not going to know about those fully for a long time. So yes, I think it's not the right approach, but it's true that, as Robin says, that it helps to understand what proportion of the population need to be vaccinated to stop this happening again. I do think the other thing about this particular coronavirus is we don't know how sustained immune responses will be, how protective they are yet, and we don't know when the next coronavirus or other viruses will come in. So you know, we have to learn on all kinds of fronts. We have to understand how to manage these pandemics. I think I've been really impressed by, you know, the work of my colleagues who are doing the technical sides of this. It's great to see these very agile responses on both the diagnostics and the vaccine approaches that help us for future pandemics, because I teach global health. I'm an infectious disease epidemiologist, and we talk to students all the time about what is the biggest threat to global health. What do you think? And of course, you know, it goes in sort of fashions, whether it's climate change or it's you know, all kinds of other things. Usually it's in recent years it's been diabetes and obesity and food and so on. And then every so often I go, well, what about emerging infectious diseases? And they go, oh, well, you know, they sort of get contained. Now, next year, I expect our students will have a quite different answer to that. These are massive threats.
Yeah. So we're getting some more questions in the chat box now. And Ambassador of Nicaragua, good morning. Thank you very much for your kind comments. It's a very specific comment for Pantelis here about producing and deploying the microchip technologies in other countries, is looking for collaboration. We've spoken a little bit about that, but perhaps you'd like just to remind us how we can contact you.
Yeah. So, I mean, prior to COVID, we were already collaborating with a number of low middle income countries. We've got a program looking at malaria in Ghana and the Gambia. We've got a program looking at dengue in Vietnam and Thailand. We've got a program looking at tuberculosis in South Africa. Now with COVID, obviously, we're also looking to apply the rapid diagnostic, you know, with those partners, but also, you know, we're open to new partners as well. So just send me an email, and you know, I'd be happy to discuss this further.
I think hopefully all of you would be happy to receive communications if there are specific questions. So there's a question here, which is an interesting one for individual schools and local areas. what data, support and solutions are practically available to them now that can help with fast, reliable detection? And what do you think could be made available by September?
Well, I can start. I mean, I can start from a UK perspective on that, or England perspective. We are have been talking to Public Health England about how to use testing to understand transmission. We know that young people and under 18s get exposed, and some of them get unwell, but mostly they don't get unwell with this virus. But it does look as if they're no less likely to get it than anyone else, and therefore they probably are transmitting this. So schools are great places for transmitting viruses, and you get the seasonal patterns of infectious diseases, particularly respiratory infections. Always you get a surge after schools go back in September, and then you get a sort of second bit of it after the universities start in late September and October. So actually thinking about how you can have rapid detection is a key question. It's quite difficult in schools at the moment. The swab tests for PCR tests are quite invasive, to be honest. If anybody who's done them, they're really quite unpleasant, and they provoke, if you stick a swab up your nose or down the back of your throat, it will induce coughing, which then, if you are infected, is dangerous. So we're hoping to get the saliva tests or other tests so that you could actually do rapid, regular testing in workplaces, schools, airports, etc. We're not quite there yet, but by September, hopefully, we will have far more technologies in place.
It's very, very good news. It's an interesting one here from somebody from Hong Kong, saying that they think that disproportionate resources are allocated to achievement in science compared to the attention to public health and behavioural changes. How do we get that balance right?
Again, I think that's a really important question, and obviously behavioural change and public health interventions are critically needed. One of the biggest difficulties with those approaches is actually maintaining them for significant periods of time. And I think everybody expects that COVID-19 is going to be a problem at least for the next 12 months, maybe even longer. So maintaining those interventions for prolonged periods of time is difficult, and will have an increasing impact on the economies of the world. So when you think about the investment in approaches like vaccines, it sounds like a lot of money, but compared to the economic impact, it's really very small. So for example, we can make enough vaccine for the UK at a cost of £2 to £3 per individual per immunisation. So the overall cost per person is relatively low. It's seen as such an important strategic priority for many governments that actually we're having to be very careful that it doesn't become too nationalistic. I don't mean just about the UK, but many governments around the world are actually trying to make upfront purchases to be first in the queue for vaccines, because they see that that's going to be most important for their economies. So it's driven by not just health, but by getting economies up and running. And an economy that's failing will have a long-term impact on the health of any nation as well.
I think, Simon, you going to comment on what you've been doing with Nicaragua? Oh, you're just wanting to make the contact, I think.
That's right, yes. We're happy to hear about the Nicaragua vaccine manufacturing capability. If you'd like to send a note to me, we'll gladly listen to that.
There's an interesting question about how the immunity of people that have recovered from the virus is being taken into account. And I think, unfortunately, we don't have time to go into great detail about that. But there certainly are studies that are being implemented at the moment to use serum from seroconverted people who've had the disease in different stages in the therapy of people with the virus. So we are at the end now of our time, and I think it's been an absolutely fascinating discussion. I'm sure we could have all gone on for a lot longer, and there were some more messages coming right at the end there. I'm sorry if we haven't been able to answer the question that you have most interest in, but I think you've heard from all our panelists that they would be willing to follow up if you have particular questions. I think this has been a very successful event. It's been a pleasure hosting it. Thank you to our many attendees for sticking with it. And I wish you and your families and friends all good health now and in future. And thank you and goodbye for now. Goodbye.